Good evening, everyone, and welcome to the AMA WA webinar this evening, which is on the last 90 days, health policy to COVID-19. And it's a pleasure and a privilege to be joined by Professor Michael Kidd, AM. Michael is the Deputy Chief Medical Officer and the Principal Medical Advisor with the Australian Government Department of Health and a Professor of Primary Care Reform at the Australian National University. He's a general practitioner and primary care researcher, past president of the Royal Australian College of General Practitioners, where many of you will know him from, and past president of the World Organisation of Family Doctors, which has the great acronym of WONCA. So welcome this evening. We hope to make it an interesting and stimulating chat for you, but also one that welcomes questions and live feedback. We do have a number of questions which have been pre-registered. But before we get into those, I'd like to ask Michael to give us a rundown of where we're up to, what the current hot topics are, and what are the things that are keeping him awake at night, if any, at the moment. Thanks, Michael.
Thanks, Andrew, and good evening, everybody. And thank you, firstly, to the AMA for hosting this webinar tonight, but thank you especially to all the members for the great work you've been doing over the past 3 months as we've been tackling the COVID-19 pandemic together. And especially want to acknowledge the work that the AMA has been doing in sharing information, keeping everyone up to date, and advocating so effectively for the role that we play as medical practitioners. I'm a little bit hoarse today because this is my 4th webinar, so excuse me there. I haven't got any other symptoms, so I've just been talking too much. I thought I'd give you a quick update on some of the figures and then an update on some of the policies which are currently in place. So firstly, at the moment, as of 3 o'clock today, we had 7,221 people diagnosed with COVID-19 in Australia. 62% of those people were people coming into the country from overseas. So the majority of the cases in Australia have been overseas acquired. In the last 24 hours, we had 17 new cases. These were from Victoria, New South Wales and Queensland, and no cases in the last 24 hours from Western Australia. 102 people have lost their lives to COVID-19 in Australia. And at the moment, we have less than 500 active cases. Part of the effectiveness of the response in Australia has been the testing, and we're just about to hit 1.5 million tests carried out for COVID-19 in Australia, which makes us one of the countries with the highest testing rate per capita in the world. So that's the figures, and I know that we're looking at the last 90 days, but I invite you to think back to this time at the start of March and how dire the situation appeared at that time, and then reflect on where we actually are now, and particularly in comparison with many other countries around the world. As you know, the National Cabinet has been established between the Prime Minister and the Premiers and Chief Ministers of the states and territories. And 2.5 weeks ago, they announced the 3-step plan to ease restrictions in a very cautious and stepwise approach to try and get people back to normal as much as we could, but also to try and get the economy restarted again in many parts of the country. The National COVID-19 Coordination Commission has been established, chaired by Nev Power, and that has issued guidance for businesses, the COVID Safe Guide to businesses, telling businesses how to reopen and to do so in a way which is protecting the health of their staff, but also protecting the health of their customers. And those COVID Safe guidelines apply to our businesses as well as medical practitioners. At the same time, we are working to do all we can to prevent outbreaks and to prevent any resurgence occurring at the national level. Having done so well over the last 3 months, we don't want to risk going backwards over the weeks ahead. And the 3-pronged approach to that is testing. So testing as many people as we possibly can. And I hope that you've all been hearing the mantra that anyone with any symptoms of respiratory tract infection or fever, no matter how mild, should be staying at home, should be arranging to get tested for COVID-19. And this needs to become the new norm for the months ahead. Every time we get symptoms of a sore throat or cough or shortness of breath or even a runny nose, we stay at home, don't go to school, don't go to work, we go and get tested. At the same time, the states and territories have boosted the contact tracing capacity so that when we do get people diagnosed, we can very rapidly identify their contacts and go and isolate those people and test them as well. And the COVID Safe app, which the AMA has been very forthright in advocating, is a component of supporting that contact tracing. And the third element with testing and tracing is isolation. So when we do get outbreaks, isolating people very quickly, putting people in quarantine, and then arranging for testing, contact tracing, and then arranging to clean the facilities where people have been. And of course, we've seen this happen in the West over the past week with the livestock ship which came in, had people who were sick with COVID-19 on board. Those people were very quickly isolated, tested. The other contacts on the ship were tested as well, and a potential outbreak occurring in Australia, because of course there were Australians on board that ship, was prevented in the West due to the effectiveness of the response to the public health authorities. We do expect new cases to keep occurring though. Our approach in Australia is suppression rather than elimination of the virus. And as I said, most of those cases are coming from overseas, mainly repatriated Australians, and of course, people being put into quarantine. But we can't close our borders entirely because we still need aircraft coming in, we still need ships coming in as we continue our imports and exports, and as we continue to have Australians repatriating back to the country. A few of the initiatives which have been carried out, which you've all been part of as part of the national response, that I wanted to talk about very briefly, and we might get some questions on these. The first was around telehealth. We had planned to roll out telehealth nationwide over the next 10 years in a stepwise approach. Instead, we rolled it out in 10 days and then refine that over the following weeks. And of course, that allowed us to continue to have healthcare services provided to the public when most of the country was in lockdown, and also enabled us to protect the most vulnerable members of our own workforce by having people able to stay at home but still reach out to their patients. And discussions are underway now about what happens next with telehealth. The AMA has been advocating for continuation of telehealth in some form, and we're working with the AMA and the other peak organisations on that. We've also established respiratory clinics right across the country. Many of these are led by GPs, including probably people who are on the line at the moment. So thank you to everybody who's been part of that process. Others have been set up adjacent to hospitals. And this, of course, is to triage patients, so we're not mixing people with respiratory symptoms with other patients, and can keep our healthcare services as safe as possible and functioning as well as possible. Very important also that we get back to normal as quickly as possible in offering normal health services. We know that a lot of people have put off coming to see their doctor because of concerns about the pandemic. Hopefully that's increasing now, and hopefully you're seeing that in your practices with more face-to-face consultations occurring. And of course, a return to elective surgery, which is again slowly and incrementally increasing at a different pace across the country as people come back to work, as the facilities are made available, and as we make sure that we do continue to have the capacity in our intensive care units available for if we get any outbreaks occurring. A particular focus of the national response has been the protection of Aboriginal and Torres Strait Islander people. And again, the West has been very effective in protecting the people in your remote communities and working with the elders in those communities on what interventions are going to be most effective in protecting the population. Of course, many of those communities are starting to open up again. And another feature which I know many of you have been involved with is vaccinating the population against influenza. And last year we vaccinated about 12 million people. This year we're aiming to vaccinate at least 18 million people, and that's well underway. But we want to prevent the risk of having a double whammy with cases of influenza and COVID-19 occurring, and the potential risk of overwhelming our hospitals. So now we're moving into the next phase. This is not the post-COVID-19 period, because we still have COVID-19 with us, and we still live in a world where COVID-19 is causing real problems and challenges. And of course, there are parts of the world where COVID-19 has not yet hit its peak. And I've been talking with colleagues in Africa over the last week where big, large population centres have still not yet been affected by COVID-19, but we greatly fear that that is still to come. We've certainly seen a dramatic increase in cases in Central and South America occurring in the past couple of weeks, and in India as well. So we need to remain vigilant, we need to remain careful, we need to continue to protect the vulnerable members of our community and continue to protect the workforce, and make sure that we're there to be able to provide the services that we do. We may be living with COVID-19 for quite some time, or at least until we have effective measures in place, including potentially a vaccine. And some of you will know better than I about how likely that is and how soon that may occur in the future. So Andrew, that's the overview, and happy to field the questions.
Well, thank you very much. That's terrific. And it does feed in well to a number of the questions we had beforehand around particularly telehealth, which has a cut-off date at the moment of September 30, I think. And presumably everyone is accepting that it's going to carry on after that. What do you think the linkage will be to need to have a face-to-face practice that opens its doors as well? And is it just a given that it will continue in pretty much the current form beyond the end of September?
Yes, so I don't think it is a given that it'll necessarily continue in the current form. The measures which were put in place were to deal with the national emergency related with COVID-19, and it really depends on what's happening in September as to which of the measures will continue and whether any of them will be scaled back or they'll be modified. Certainly in introducing the widespread whole of population telehealth measures, the intention was that these would be available, but that if people needed to have a face-to-face consultation, arrangements will be able to be made to have that occur. Now, clearly, some of the telehealth operators which have established are operating in one part of the country, seeing patients in another part of the country, and cannot possibly be actually seeing those patients face to face. And that is not the intention of the measures that we put in place. So there do need to be some modifications made, and we think that there may well be a lot of examples where people for the first time do need to be seen face to face, and then perhaps subsequent consultations can be by telehealth. But that establishing a relationship with the patient is very important and is more difficult by telephone particularly than when you're seeing someone face to face. And of course, much of what we do in clinical medicine does require being in the same room with the patient and the provider. So we'll see what happens. The AMA, as I said, is very involved in the consultations about what telehealth may look like in the future. It may be that we have different arrangements for GPs than we have for other consultant specialists, than we have for other healthcare providers. We do recognise that telehealth has opened up some great benefits, particularly for providing care for people in residential aged care, expanding the care for people who are homebound, so the frail elderly and people with disability, and a lot of convenience for many of our patients. And there are probably a lot of savings which won't be seen in the health budget, but will be seen elsewhere through people not having to take a whole day off work to go to a health appointment and sit around and wait. And so much of this can be done much more conveniently. We're still, of course, learning a lot about telehealth, and most of the consultations have been by telephone. And I think we need to be moving towards a lot more happening by video consultations.
Thanks for that. It obviously has had its teething issues, and there has been some issues around mandatory bulk billing for GPs for certain types of patients, not for all patients, but certainly for vulnerable patients, which has been interpreted as discriminatory, and the anaesthetists weren't too happy that they weren't included until the 22nd of May. So we would hope that there's time for, as we go along, for fulsome discussion around those things, and that this finds its place in the constellation of clinical medicine in a way that doesn't disadvantage the patients or the practitioners will I think be our line, just to have that conversation that we haven't had time for. But it is interesting, as you say, that it came in 10 days. We've introduced a whole program, and now we can at least have a straw program that we can all poke holes in and say this might be a better way to improve it. Onto testing. This obviously is going to be a feature, and I had the pleasure of having a nasal swab myself today. I think I've almost stopped tearing up at the moment, but hopefully they'll figure out a better way of doing it soon. But certainly that's going to be a feature until a post-COVID world, and just wondering how you see that fitting into things like protecting our hospitals. We're obviously keen to understand why we can't do pre-operative screening, and also our travel. You know, clearly there's some controversy around the closed border in Western Australia, and PCR testing, unlike antibody testing as I understand it, is pretty specific and sensitive, although there is of course an incubation period to deal with as well. But what role do you see testing having over the coming months? And I guess in a lot of these hundreds of webinars that you're doing, you're being asked to be a bit of a futurist, but you're a bit ahead of the pack, so you can see a bit further down the road than we can.
Well, I think probably the pathologists who are online are more ahead than I am on a lot of this.
You talk to a lot of pathologists, so I'm quite sure you can tell us what they think too.
That's true. So look, I think testing is with us for the foreseeable future, and you know, we had a lot of questions saying, well, aren't people going to get tired of being tested every time they get a respiratory tract infection over the months ahead, and particularly concerns about parents who may decide after their child has had respiratory infection number 3 or 4 during the winter to stop the testing. But at the moment, because we still do have community transmission occurring, at least in the eastern states, we do need to keep testing and keep the testing rates up, and we are still picking up people through the tests who are surprised that they're positive, and it includes people working in healthcare settings. So there have been a number of people, healthcare workers in hospitals, community clinics, and especially in residential aged care, who've been picked up by temperature screening before going to work, and also by questionnaires with very mild symptoms have been tested and found to be positive, and therefore we've averted potential outbreaks occurring in those settings. So we do have to continue to remain vigilant. The PCR tests, they do have a high rate of sensitivity and specificity. We do still get some false positives and some false negative results occurring though, and that's not surprising because that of course occurs in every test, and we are conducting hundreds and hundreds of thousands of these tests. So if you do get a result and you think that doesn't seem right, don't be afraid to repeat it, even if your patients don't thank you for doing so. As I'm sure, Andrew, if your treating doctor recommended tomorrow that you have the test again, you'd probably not be too happy about that.
No, I'm not going back. But we have seen some cultural barriers to testing in Western Australia. We have reports from GPs of kids being refused at the COVID clinic by the staff there, and those are kind of happened. Those rumours are happening enough that I think that it has some substance to it. So we do need to make sure that the government's message that's coming out is that, you know, we test at the drop of a respiratory symptom hat. There has to be, you know, there's no shortage of willingness in private pathology, but I think in the government setting we do have some work to do there. And there is a question online about the C pass from Singapore for antibodies. Will we get to a stage where people have a COVID passport and will move among us like golden gods, untouchable by the rest of us, or touchable?
Well, the challenge there rests with the antibodies and the antibody tests. And there's still much we're learning about COVID-19. So if you are infected, does everyone develop antibodies? How long do those antibodies last for? If we're testing and we test someone for antibodies, at the moment, some of the tests are not as sensitive or specific as we'd like. Some of them also test positive if you've been exposed to other coronaviruses, including those causing the common cold. So there are all sorts of challenges with antibodies, and the passports, and these have been mooted as a passport for people to return to work, a passport for people to be able to travel. The risk with these passports is that you may have had antibodies at the point that you got your passport, but you may not have them now. Does that mean you're susceptible to reinfection with COVID-19 or not? Have they been counterfeited? Have we got people who actually go out and actively seek to get infected in order to get their passport and put themselves at risk? And we know that even among young people, we do get deaths occurring from COVID-19. This can be a very serious illness. So there are a lot of unknowns around the testing, and a lot of things we're still learning about the antibodies, and hopefully the antibody tests will improve. We've got a number which are under investigation, being researched here in Australia at the moment, but we're still learning quite a bit. You've got to remember, we've only been sharing the planet with this virus for just over 5 months, so there's still a lot to learn.
Extraordinary, and human behaviour always remains extraordinary. I'm reminded of my patient who told me that she had to put on weight in order to qualify to get her gastric banding surgery done. And that's that humans will behave in unpredictable ways. In terms of the borders, this is obviously an issue of great discussion here. We talk about a closed border, but that's not really true, is it? And part of the reason we have to accept that we're not going for elimination in WA is that there's quite a few people still coming and going across our internal borders, our state border, as well as internationally, obviously, on shipping. Is that our main area of risk of arrival of disease here?
Yes, so as I've said, the majority of infections diagnosed in Australia have been related to people coming into Australia from overseas. And as the pandemic continues in other countries, that risk will continue. And as we've seen with the ship that docked in Fremantle last week, and people being infected on board. And that's why the quarantine is so important. That 14 days of supervised quarantine that was imposed around the country has actually been very effective in preventing further community outbreaks from occurring in all of our states. But we do have people moving across Australia and coming into the States as well. And of course, there are exemptions being provided for people coming into Western Australia. People come in and are then required to isolate for 2 weeks. But we do have essential workers moving backwards and forwards. We have the fly in and fly out workers going to the oil rigs and up to the mines. We have healthcare providers coming in and out of the countries. We have people coming across for compassionate reasons when they have family members who are gravely ill or who pass away. So there's continuing movement across the country, even though ostensibly some of the state borders are closed.
What do you think about the PPE? That's the other big issue that we have going on, obviously. Is that something that worries you at this stage, 5 months into it still? And what is your sense of the N95 situation for those people who might need to treat big numbers of COVID down the track if we mess this up?
Yeah, so you ask about what causes loss of sleep. What was causing me loss of sleep 3 months ago was the PPE situation in Australia and all around the world. So 3 months ago, there was a global shortage of PPE and especially masks. And that was having an impact in Australia. We had orders out. Of course, much of the global supply of PPE was coming from China, and ironically, much of it coming from Wuhan. And we did have marked shortages occurring in many settings across Australia, including for general practitioners and people working in the community settings as well as in our hospital settings. Part of the national response to COVID-19 has been to protect our healthcare workforce and to protect our healthcare workforce no matter where they're working. So not just protecting people working in intensive care or working with people diagnosed with COVID-19, but particularly early in the pandemic, recognising that any healthcare worker in any encounter could be encountering somebody with COVID-19. So the need for that protection was huge. It was a great relief when the planes started arriving containing millions and millions of masks, and we were able to start distributing those masks either through the hospitals directly or through the primary health networks, which acted as the agent for distributing PPE out to general practice, to private specialists, and to pharmacies and other settings. The need for PPE is still there. The settings in which we need to be using PPE, of course, now is different. So those people working in the respiratory clinics, they need the full kit in order to protect them, because they're swabbing and assessing people with respiratory symptoms. For many of the rest of us working with our patients, the standard precautions may be appropriate as long as people are not exhibiting symptoms, and particularly in areas of the country where community transmission appears to be either zero or very, very low.
So we do have the luxury of spending some time trying to sort that out and make sure that the gap between the good intention and the resource of the government and what is delivered on the front line in terms of what a GP has in their available in their practice to see fever patients, or what's in an aged care provider's facility, because this is what the AMA hears a lot about, is the gap between what's supposed to happen and what is happening. So this time is buying us that that sort of luxury of working these things through. And clearly there will continue to be some discussion between infectious diseases experts who form guidelines and those who work in these areas, who see the situation as a lot less predictable and tidy than the guidelines necessarily anticipate. But we did just mention aged care, and I'm just wondering how you feel about the preparation of that industry, which of course was mid-Royal Commission being pilloried for its standards of delivery in many respects. And suddenly we get confronted with this. So how confident are you, is the government, that we can respond to effectively to a number of outbreaks in those kind of facilities?
So obviously, residential aged care facilities are one of the most vulnerable settings in the country, and because of course there are large numbers of people there who are at risk of death if an outbreak of COVID-19 occurs. And we have seen that happen very sadly in a small number of cases where COVID-19 has got into residential aged care facilities, and we've seen significant numbers of deaths, particularly with the Newmarch house in Sydney. Fortunately, our residential aged care facilities across the country, as part of their mandatory accreditation, are required to have pandemic plans. And these have been in place for quite some time. And as soon as COVID-19 appeared, the pandemic plans were put in place. And I have to say that from my perspective, the majority of residential aged care facilities in the country have actually acted magnificently in protecting their residents through going into lockdown very early, through screening their staff and any visitors coming into the facilities. And as I've mentioned, we have had people turning up to work not realising they were febrile, being temperature checked, having a fever, going away, getting tested, found to be positive, and therefore not transmitting. And we've had, I think, over 20 residential aged care facilities where there has been contact with someone with COVID-19, but only a small number where there's actually been an outbreak. occurring amongst the residents. So we've had a number of near misses, but near misses which occurred because of the mechanisms which are being put in place to protect the residents. We also have concerns about the home care arrangements. So again, many vulnerable people, elderly people, people with disability living at home with multiple providers going from home to home to home. And a lot of the work the Commonwealth has done has been around infection control training of those people. And we've had over 700,000 people who've work in healthcare, aged care, disability care, take part in the Commonwealth's online training and infection control support to try and reduce the risk to those populations as well. But I think in Australia, we've been incredibly fortunate. If you look at what's happened in the USA, the UK and elsewhere, there has been absolute devastation occurring in residential aged care facilities, huge death tolls. Many people dying who, to date, I don't think have actually appeared in their official statistics. Yeah. I think it's been underreported and probably grossly underreported. And very fortunately, we haven't had that situation occur in Australia.
Yes, and I think telehealth is also obviously where it can be implemented been useful, and we need to tidy up communication with relatives and that sort of thing in situation of lockdown. So there's work to be done there, but hopefully the standards can be improved. And hopefully what we're hoping is that the politicians recognise that the popularity that they have is attached to low case numbers and avoiding what's happened in these other places. And it almost seems like a different disease, doesn't it? And going to the other end of the scale, there's obviously a lot of concern of the other people we have to look after, which is the kids. And there was that study from New South Wales, which was an interesting one to me because it studied a month in I think it was 15 schools following 9 cases. And it did show transmission between students in the schools, even though it was only 2, I think, who picked it up in the school environment. Correct me if I'm getting this wrong, but that was one of the main studies which was used by the government to say that it was safe, and perhaps to put a little bit of a gloss on that and say it was the safest possible place for kids to be, whereas I actually think that's locked in a cupboard somewhere. But for a while, with appropriate ventilation. That's just my kids, not everyone's kids. But I think I'm interested to know what we think about the spread of disease, how we feel about, the balance with educational, social requirements versus what will happen if we need to be coming and going from school a lot. Will schools have to be completely different from now on?
Yes, so of course our schools are now reopened right across the country. In some parts of the country they never closed. But certainly attendance reduced dramatically when we're in lockdown in most parts of the country. The decisions and recommendations made by the AHPPC, the Australian Health Protection Principal Committee, which I'm one of the members of, was based initially on the evidence that we were seeing coming from overseas. So much of what we learned about what happened in China, then South Korea, Iran, Italy, and so forth. And then based on those studies, and that study you referred to was one of the first ones at schools. Fortunately, in children, there is lower transmission of COVID-19, and fortunately, the vast majority of children who are infected have mild symptoms only. We have had those few reports coming from overseas about the Kawasaki-like syndrome and the other inflammatory conditions, but that is incredibly rare, or appears to be incredibly rare. And the balancing issue, of course, with the schools is the concerns about children being away from the educational environment for a prolonged period of time. And although some parents were able to do homeschooling and do it very, very effectively, not all children had access to those opportunities. We're especially concerned about the early learners. We're concerned about children with learning difficulties. We were concerned about children who were separating from school and the risk that a prolonged period away may mean that they would never return to school. And we were concerned about the senior students and the impact that being away from their classes was having on their preparation for the exams and the important events that were going to have an impact on their future lives occurring as well. So, I know a lot of people in the country are very glad that the schools have reopened, and obviously the measures are in place to try and protect both the children and the staff in the schools, and every school has been required, as every business in Australia has been required, to do a risk mitigation exercise to look at how to reduce the risk of introducing COVID-19 into the school, and then how to reduce the risk of any transmission. And when an outbreak does occur affecting a student or a teacher in a school, as you've seen over the last few weeks, the school is closed. People are put in isolation, testing is carried out, thorough cleaning occurs, and then decisions are made by the state authorities as to when it's safe for that school to reopen. And we do expect this to be happening episodically over the coming months as we learn to live with this virus. The most important message, though, which I said right at the start, and I know it's a message that all the AMA members are pushing with their patients, is if you have symptoms, you don't go to school, you don't go to work, you stay home.
And that is a massive cultural change, isn't it, for Australia?
Absolutely.
Because we go to school and we go to the work when we're sick all the time, and this is not going to be easy for parents. And I've been wondering how much of the flip from bring your kids to school, we're encouraging it, to it is now compulsory to bring your child to school, is economically based, because we want the parents to be back at work, and how much of it really is about the welfare of the children. Why wouldn't we just leave it to the discretion of the parent to say, in our family situation, it's easy for them to be off school, we have particular reason why we don't want this disease in our family? Why wouldn't you trust families with that?
Well, I think that is a challenge, and there are a whole lot of areas where personal decision making is occurring. And if you live in a household and you have a vulnerable family member, and do you want to keep everyone in the household together and away from the rest of the herd? If someone is immune compromised, do you want the children going to school and putting that family member at risk, or having to somehow isolate people within the family home, which is, of course, incredibly difficult, if not impossible, to do with small children. And we're seeing this area of personal responsibility in a number of other settings as well. We're seeing it with the debate around public transport and the risks about getting onto public transport if it's crowded. We're seeing it with the debates about elevators in high-rise buildings in our capital cities, and people being concerned about getting into a confined space with a large number of people not able to adhere to the physical distancing. We have revised the advice on the public wearing face masks, even though we don't recommend the public wearing face masks. We recognise that people may make a personal choice if they're getting into a setting where they don't feel comfortable, and that is what they might be doing. So there is a lot of personal responsibility attached to our lives as part of this pandemic, and people making individual decisions as well.
Yeah, well, I mean, one of the things that we've seen some conflict and some cultural change, because everything's had to change so quickly, is the idea that some healthcare workers who may have immune conditions themselves or whatever want to wear droplet precaution all the time at work, and of course, because they cannot socially distance. So we may get to a point where that's more sympathetically viewed by managers, because we'll just get used to the idea as we go along. And what we've been calling for is a bit of empathy, a bit of flexibility, and not too much in the way of stressful rigidity here. But speaking around regulations and things, you did say that having a COVID-safe plan for your business is a requirement for the reopening of businesses. And I think you said that that's also a requirement for medical practices. So is it the case that if we've got people online who are running medical practices who don't yet have a COVID-safe business plan, that they'd better get on and organise that pretty quickly?
Certainly recommend it. So medical practices, of course, are businesses. And so the COVID-safe business plan is put out by the NCCC, the National COVID-19 Coordination Commission, and it just guides you to step through. And I know that most medical practices have done most of this already in the decisions that we've made about how to protect our patients, how to protect our staff, the physical distancing measures that we've put in place in our waiting areas, asking our patients to not just front up, but to make appointments, the triaging of people with respiratory symptoms, and so forth, the advice that we're giving to our staff, including ourselves and the other doctors in our practices, about not turning up if we're symptomatic. And I think you've struck on a really important point there, Andrew. You know, many of us have gone to work with a bit of a cold in the past and been scrupulous with our hand hygiene and our personal hygiene so that we don't transmit things to our patients, but we can't do that now. Fortunately, we have telehealth, so if we do have to take a couple of days off work while we stay at home in isolation, get a test and wait for the results, we can still be consulting with our regular patients using telehealth and not putting them out of making things inconvenient for them.
Yeah, I think that's very reasonable. To what degree do you think we are being realistic as we have businesses opening up and we see things starting to liven up? We're getting in Western Australia up now to quite large numbers of people allowed in restaurants and that sort of thing. And we're down to 2 square metres. Should we be telling these big businesses that rely on crowds that until we get into a post-COVID era, you need to assess your viability? Because if you run a cinema or if you run festivals, concerts, pubs, presumably your big profits rely on big crowds, particularly being inside in a lot of these locations. And we're not going to be able to get to that stage, surely, for quite some time until we have some herd immunity, I would have thought.
I'm not sure that we'll ever get herd immunity to COVID-19. We're not sure that actually any
vaccine,
country.
I mean, yeah, with
the vaccine, yeah, and the other protection, absolutely. Look, the National Cabinet only 2.5 weeks ago announced its 3-step plan of how to get businesses functioning, but doing so in a cautious, incremental state. And some states are still working out how to implement step 1, and some places have moved to step 3 already. And I think that we do need to be really cautious. The issue about large numbers, a lot of us, or some of the states, are requiring that if you open up your restaurant, that you have the contact details of every customer who's come into your restaurant. So if you do get someone who is diagnosed, we can go back and we can do the contact tracing of everyone else who is in the facility. And I guess eventually, as the numbers get so large, that becomes not possible or not feasible to do. The app on our phones is another way of helping to protect ourselves by making sure that the contact tracing can occur. And we may well see, as the crowds start to increase, that more people download the app. Certainly it's been used by contact tracers in a number of the states already to identify people who otherwise weren't known or recalled to have been contacts of somebody who was diagnosed with COVID-19. So, you know, from the public health perspective, I think we need to be doing this in an incremental way rather than going at it really fast. I know some businesses are really pushing governments to allow exemptions and allow their facilities to open. But you know, this may be where we risk getting resurgence or even the second wave if we do too much too quickly. It is this balance, isn't it, between the health of the community and the health of the economy, and we've got to get the balance right.
Yeah, and I suppose the AMA will be advocating that we have to be honest, and if we're not going to have festivals for a few years, let's just acknowledge that now, so that people don't invest unwisely, I suppose. Just a few quick questions that have been pre-registered that might be things you need to take on notice. There's been some talk around the standard of masks, and there's been a bit of stuff circulating around how to tell if you've got a counterfeit mask. Do you have any insight into the integrity of the national stockpile, particularly around N95s and things like that? If we get into a surge, are we confident that those things are all TGA okay?
Absolutely. So the national stockpile only contains items which have been approved by the TGA and they're assessed as they come into the stockpile. So we know what's going out of the stockpile meets the standards which have been set. We have had concerns about masks which have been sold by private providers, which don't meet the standards or are not TGA approved. And this includes masks which are being sold to the public as so-called surgical masks, but are actually not. And so people have to be very careful. We as medical practitioners, if we're buying from private providers, please make sure that you're buying from your trusted suppliers, and make sure that your trusted suppliers are verifying that what you're buying has been approved by the TGA and meets the TGA standards.
But it still is the primary responsibility of everyone who's outside the public system to source their own PPE at this stage, isn't it? Although it's been intimated along the way by Health WA that they will help if they can, sort of thing, but that's not a reliable thing. So we still need affordable, accessible and quality PPE to be bought by the private sector.
That's correct. We have been, to date, we have been supplying general practices, and particularly the general practice respiratory clinics, from the national stockpile. And that was because at the time there was very little or no private suppliers coming into the country. So we were using the national stockpile to protect the workforce. But now that we're moving back to a degree of normality or new normality or whatever normal looks like, yes, the expectations are we're moving towards people purchasing their own PPE as they've always been doing from their own providers.
In terms of the comorbidities and the flow-on effects of this, to what degree is the AHPBC keeping an eye on something like the suicide rate and the comorbidity, the unusual death rate from other disorders?
Yeah, absolutely. So working very closely with the states and the territories, with the Australian Institute of Health and Welfare, and with the coroners on making sure that we're keeping across what's actually happening with death rates across the country, partly to make sure that we're not missing COVID-19 cases, and we don't believe that that's happening, but also, as you've rightly pointed out, right from the start of the pandemic, we've been very concerned that the consequence of past epidemics and pandemics has been the impact on people's physical health, where people have been putting off getting checks for acute symptoms, have been delaying the management of chronic conditions and the attendant morbidity and mortality that may result from that, and also the concerns about the mental health and well-being of the population. The population has been through a hugely stressful time with, I think, everyone in the country having a degree of anxiety, but also many people having lost their jobs, being really struggling, and the significant risk of self-harm and suicide increasing over time. So there are a lot of measures which have been put in place to support the mental health and well-being of the population. We've got research underway at the moment looking at the mental health impacts of quarantine and isolation, and the healthcare workforce has been looked after as well. So the Black Dog Institute has been funded to provide a new resource specifically for healthcare providers called the Essential Network, or TEN, and this is available free of charge for all healthcare workers, including all AMA members. Please, if you feel that you are feeling more stressed or distressed than normal and you feel you need someone to talk to, please reach out to the resources at the Black Dog Institute or Beyond Blue or Lifeline, the other supports which are available. If you're worried about one of your colleagues, please reach out to them as well. A lot of people are under a lot of stress at the moment.
Yes, thank you for that. I mean, it's a great concern for our members too about patients that they haven't seen in the meantime, and this. To what degree do you think that this is a straightforward balance between economy and restriction, and to what degree do you think that preventing disease actually will help us on the economic side? I mean, you sit around as they talk about these modelling sort of things, and like all modelling, obviously it's a little bit looking at the tea leaves, but is it your sense that keeping the case numbers very low with severe restrictions and bad economic damage early is going to give us a better economic run in the long run?
Yeah, absolutely. So just a couple of things there. The first thing you mentioned, Andrew, was about concern about our patients we haven't seen for a while. And of course, using telehealth, we can reach out proactively to our patients. So if you do have a patient with chronic disease or a patient who you're managing for mental health concerns and you haven't heard from them during the lockdown period or since then, please reach out, and you can use telehealth and the MBS items to do this. The consultation can be initiated by the provider or by the patient.
It's an important point.
It is. And the other issue about our economy, you know, it may well be that we are in a bubble in Australia, and New Zealand's in a bubble, and a number of the other island nations like Taiwan and Iceland and elsewhere are in bubbles as well, and protected by the fact that we are island nations. But this also may be a positive for our economy. For example, we're looking at the moment about whether it's feasible to reopen our universities to international students from around the world. Obviously, they'd have to go into quarantine and pay for that for 2 weeks in hotels before being allowed into the wider community. But with Australia being seen as a safe haven and with international students being, I think, the third most important element of our exports after the minerals, it may be that we start to open up and there is a positive to coming to Australia. It may be in the future that people looking to vacation would come into Australia, be willing to pay for 2 weeks of hotel quarantine in order to have holidays in Australia. The other thing is, of course, as we open up our state borders, we're not spending money as Australians travelling overseas. And that money can, of course, be spent travelling around our own country and boosting our own economy. And so there may be, a balance which is struck here. And of course, if we open up the trans-Tasman bubble with New Zealand, I'm not sure how keen New Zealand is. They only have one active case of COVID-19 at the moment. We have about 500, so it may be a while before that border opens. But we may have benefits occurring there as well.
Yeah, it is a fortunate range of options to consider, and really very different to where we were 8 or 9 weeks ago in terms of the range of options we were considering. So it requires us all to go back to the sort of blank page again and say, well, now that we're in this unexpected position, we have a different set of priorities and a different set of worries, I suppose. Speaking of which, the people who are considering all that around the National Cabinet, you've been around the block a couple of times. I mean, you've been the president of a college, so you know what endless, pointless meetings are all about. And policy papers and so on, and trying to get something good out of all of that stream that flows past. Well, are you optimistic about the new system for engagement with the different governments?
Look, I think the partnership that we've seen throughout the pandemic in Australia between the Commonwealth and the states and the territories has been unprecedented. The establishment of the National Cabinet is something that's very new, and it seems to have worked incredibly effectively. Yes, the decisions are made at the national level, and then it's up to the premiers and the chief ministers to determine how they roll out at a state level and what works best based on the epidemiology of the pandemic in each of the jurisdictions around the country. But I think the system has been working really well, and it's what you'd hope would happen during a national crisis, during a national emergency. And I think we've been very fortunate with the leadership that we've had at the national, state and territory levels, and with the AMA members and others who are the people providing the advice to our leaders around the country as well. Whether that continues as the pandemic continues, or whether it continues after the pandemic, who knows? Guess we'll wait and see.
Well, I suppose there's always politics involved there, but certainly, as someone who's part of a lot of robust discussion in the public arena, I don't see it as a disadvantage at all that there are different things being tried in different states and that people are moving at a different pace, and then they all get back around the table and they argue about it. And, there is the public argument, but I'm quite sure that behind closed doors it's a lot different to that, and everyone is really quite open-minded about it. But you're right, I suspect having an urgent common enemy is something that does unite, and that we may see something a bit more political and divisive as we go along, but we'll certainly be trying to capitalise on this to get maybe some progress around other things like the gap in Indigenous health and reform to the healthcare system in general in a positive sense, so that we can capitalise on the current goodwill that's going on in terms of change, or the ability to change things. So I'm not sure, though, that you have directly answered what's keeping you awake at night at the moment. You did say a few months ago. Are you allowed to tell us what's keeping you awake this week, or is it nothing?
No. I think, like most people in the country, I'm still waking sometimes in the middle of the night, and the head is spinning and concerns. What am I concerned about? I'm concerned about whether some of the restrictions are being lifted a little too quickly in different parts of the country. I'm concerned about the outbreaks which we are seeing, and making sure that we are addressing those very effectively and well. And I think our states and territories are doing that incredibly well. I'm worried about whether we have any potential for hidden outbreaks occurring in Australia. We saw in Singapore that they have had a resurgence occurring amongst the foreign workers who live in the dormitories, who were not thought of as being part of the national response the first time around. And we've just done some work. I chair with Sharon Lewin the National COVID-19 Health and Research Advisory Committee, which provides advice to Brendan Murphy, and we've just done a review of where might hidden populations and hidden settings actually be across Australia, and tried to be as comprehensive as we can, because we saw an outbreak in a meatworks occur in Victoria, and there have been a number of those outbreaks, and they've been terrible in the USA. We've seen outbreaks in residential aged care. We haven't seen outbreaks, thank goodness, in remote Indigenous communities in Australia, and let's keep it that way, protecting Aboriginal and Torres Strait Islander people, and working with their elders to make sure that protection continues. But I'm still worrying about things, and I think we all are. I think that there still is this level of anxiety amongst most of us, and I know that exists for many doctors. Many of us are worrying about the patients, as you say, that we haven't been seeing. Many of us are worrying about the people who are turning up now with long shopping lists of things that they haven't had attended in the last 3 months. Many of us are worried about patients who've turned up with worrying symptoms, which could be an underlying cancer, and they've been sitting on the symptoms for 3 months, not being investigated. And many of us are worrying about our patients with mental health concerns and the impact that this is having on them. So I think we're probably all together. When you do wake up at 2:30 or 3 o'clock tomorrow morning, just know that you're not on your own.
Well, that was
all of this as well.
And that was the point of the question, because what I was going to worry about in the middle of the night was if you told me, oh no, we're all really relaxed about this now and we think it's gone away, because that's what I fear in the general community and in the less sophisticated, educated politicians amongst the ones who are easing restrictions in places. And I think, like you, I worry about that, and that'll be some of the battle to come. But I want to thank the participants for dialing in this evening, and if there was a question specific that we didn't get to, then we'll undertake to follow that up afterwards. So please keep in touch with us. So thank you from the AMAWA. And Michael, thank you for your eloquent willingness to be open and frank with us about where we're at. And I appreciate too the time difference that you're getting many of these back to back to keep us informed, and we'll spread the word. And the thanks is coming through on the chat as well from many of the participants. So thanks for your time tonight, ladies and gentlemen from the AMAWA. We will make this one available online on YouTube down the track so that others can catch up with it. Thanks and good night.
Thanks all.